Tonight I'd like to share with you some concerns that I have about the impact of P3s in our healthcare system and what it holds for me, for you, for patients, and for care providers who work in the system. Professor Alison Pollock and Mark Hellawell just completed a study in December of the impact of P3s in the Scotland National Health Services. Once again, the study showed P3s cost more than non-P3 buildings to run. These extra costs meant financial resources were diverted from clinical services, staff, and supplies. So what do cuts in clinical services, staff, and supplies mean for the quality of care you receive? Well, we can just look at examples that I hear from nurses every day in British Columbia to talk about it. Laundry, just not enough access to clean linen. Food, not nourishing, not palatable, not accessible. If you, many of you are looking like you have daughters who might be having babies, so we won't talk about your partners having babies, but maybe your daughters. If they were laboring all night and delivered their baby at 3 in the morning and hadn't eaten for 18 to 24 hours, it wouldn't matter because there's no food. We used to be able to give people food, a piece of cheese, a piece of toast, a cup of tea. There's no food anymore, so you better get ready to do the run to, your local convenience store for a hamburger or something because it's just not there. Things like this are shocking to hear when you think about our system. It goes even further, though, when you look at long-term care, where staff are being advised to not change diapers more than once in 24 hours. Where seniors are only entitled to a bath once a week, where the team comes in and like a machine puts them on a conveyor belt in and out of the tub. It's almost like a car wash, for God's sake, the way the seniors are being treated to their baths. This kind of lack of attention to basic needs of patients, never mind the more serious health needs that need to be met, where expert clinical staff is reduced and replaced by less skilled workers, and often in many less numbers, is a travesty. It's also diverting, quite frankly, funds away from the prevention system that we need to put in place, from our home care services that we need to put in place. So, the impact of that diversion of funds is quite significant. The latest study from Pollock about P3's impact on Scotland's NHS also shows that these projects create a much greater debt over time than the investment they provide. And I'm just going to skip over some of the costing, but just to tell you that the total value of PFI contracts in Scotland is £602 million, but the debt created is in the order of £2.4 billion. How's that for sustainable healthcare for the future? And this is the preferred and only method our government wants to look at for funding new projects here in BC. And the impact on the health authorities in Scotland is predictable and unacceptable. Less money is going for programs and services that were previously provided. And yet, despite all the evidence, Scotland too is expanding their PFI program because international forces and players are driving this agenda in the interests of shareholders and investors, and clearly not on the impact of working people like you and I. What hallway will you lay sick in instead of a hospital room? Or if an elderly person dies without the attention and care of a nurse by their side, how will you answer to that person's family? The large players are in this healthcare game only for profit, and they will dress it up as consumer choice and competitive efficiency. Well, we have choice here. We have choice of physician. We have choice of generally facilities. What we don't have is a choice to mortgage our home and mortgage our futures in order to pay for our healthcare services. And this is what we have to tell others. I recently came across a paper from a British GP, Dr. Elizabeth Barrett, that was written a couple of years ago, and it was billed as an invaluable insight into the privatization of primary care, a development concealed beneath the rhetoric of patient choice. The good doctor was a GP in her community for 20 years and approached her health authority with a proposal to set up a multidisciplinary clinical team to improve care in her community. And this, by the way, is something that the Nurses Union has researched extensively and has put forward as a proposal for improvements in the British Columbia healthcare system. The local government agreed to donate the land, and when they were getting ready to pick who was going to run the clinic and provide these services, they ended up with a private sector bidder who won the contract. United Health Europe was the preferred bidder. It was billed as a young British company, but was in fact the largest healthcare corporation in the US. The end of this tale should serve as a warning as we hear our current government speaking now about the possibility of having primary healthcare clinics here in BC under the P3 model. I fear that they are not referring to the community healthcare centre model that we have been advocating for and others have been advocating for, a model where 24/7 service is available from a range of family doctors, nurses, nurse practitioners, and other facilities, a model where the community has an actual say in their own healthcare services. No, despite all evidence to the contrary, it appears that British Columbia is headed down a similar trail to that experienced in the UK.
We're going to be using P3s to build the new South Fraser Perimeter Truck Bypass Highway. We're going to build the Pitt River Bridge.
Private clinic owner and promoter Dr. Brian Day is pushing for a competitive funding model between hospitals now here in our province. The same model which has resulted in huge deficits for the UK health authorities and closures, service cuts and layoff for staff. And the BC government is listening to Dr. Day and promoting the idea despite the fact that it will mean accountability and fairness will take a back seat to profitability in determining which medical services a hospital provides. Hospitals will end up competing for the most profitable patients, those with low costs. Smaller hospitals outside the large metropolitan areas won't be able to compete at all. And like in the UK, private for-profit clinics will receive guaranteed funding and compete with public hospitals. Competitive healthcare is contrary to the collaborative teamwork approach to healthcare that we endorse and which often results in the best quality care and shared advancements in treatment and success. I'd like to give you one more piece of evidence that shows that P3s and the competitive UK model what they may do to undermine the care you receive, as well as nurses' ability to provide that care. Another study of P3s in England at North Durham showed that 27% of the expenses were to cover higher borrowing costs, fees, and profit for private corporations, none of which would be necessary if it was built publicly. Beds and staff had to be cut to make the new hospital affordable. Nurses were cut by 12%. Now remember that in British Columbia, we already have the lowest ratio of nurses to 100,000 population in the entirety of Canada, next only to Nunavut. So nurses in BC are already a rare sighting in your healthcare system. And under this proposal, if we reduce them further, well, we'd be pretty close to extinction. And if we look at the British P3 system, they've been cut on average 14%. What does that mean? As the Guardian newspaper reported, back in the new hospital, these dry statistics are translated into day-to-day experience. Senior nurses talk with distress of being unable to give basic care. There was one patient, and this is a quotation, a man in his 40s who was terminally ill, one nurse recalled. I'd been nursing him on and off for 7 years. Shortly after we moved into the new hospital, he died. It was 4 hours before I noticed. I just hadn't had time. He wasn't shouting at everyone else, so I didn't have time. There were 4 staff, 2 qualified RNs and 2 assistants for 32 patients. That's normal now. It's against everything you're trained to do. I came into nursing because I want to look after people. Well, those nurse-patient ratios aren't out of line. I've been to Surrey, acute orthopedics, 1 RN, 14 patients. Acute orthopedics, folks. Another nurse said, I'm having to say, I'm sorry, you'll just have to wait. I've got 3 urine bags under my arm already and I'm trying to do the drugs. Your bag will have to wait. Every day you say to yourself, God, what if that was my mom or dad? It breaks my heart to hear those words from nurses, and increasingly I hear it from nurses in BC. I believe we can turn back the tide. We can come together, all of us, and say no to what we know is wrong for healthcare patients and for Medicare and for healthcare workers. Why is it that our federal and provincial governments cannot get together and put in a public infrastructure program? They've put it in the past for highways and other works projects. Why can't we be turning our surplus budgets into a public infrastructure program which would provide for ongoing hospitals, long-term cares, and education facilities for this generation and those to come? And those are just a few of the questions we should be asking. Is it really the only alternative to privatize? I think not. In Canada, our Medicare system belongs to us, to you and to me, and it is not for sale. Thank you.